Morning, everyone. Welcome to the Common Part B Urology Rejections and Denials webinar. My name is Mary Muko. I am a member of the WPS Provider Outreach and Education team, and I'll be your presenter today. I'm joined by my friend and teammate, Bailey Lawson, who will assist with some behind-the-scenes help. This webinar is for those people who are wishing to learn about the most common reasons for rejections and denials on Part B claims submitted to WPS by urology specialty providers. CMS requires the MACs, the Medicare Administrative Contractors, to include this education in order to prevent future claim rejections and denials. And just as advertised, the information that I'm presenting in this webinar is actually based on WPS claims data. The presentation is available to download from our live events webpage. The page address is in the chat. You may take time to download it now if you haven't already done so. We will record this session, and barring any technical issues, we will post the recording on our Encore presentations webpage, where it will remain for about 60 to 90 days. The recording will also post on our YouTube channel, where it will remain as long as the information remains current, or we otherwise decide to remove it from the YouTube channel. Now, if you have questions, please put them in the chat. I will answer questions as time permits, but if I don't get to your question, I will either email a response directly to the learner following the webinar, or I will prepare a list of questions and the answers and share them with all of those participating in the webinar today. I am unable to provide answers to claim-specific questions. I don't have any access to claims data. So you may contact customer service if you have a claim-specific question, and they'll be able to access those claim details in the claims processing system and will respond to your questions. Here is a disclaimer that we include in all our live events, and it's really here to let you know that this presentation is for educational purposes only. I did make every effort to verify the information that I'll provide is current and accurate, but you do need to know that it is subject to change. It is on the CMS website, where you can find Medicare rules and regulations that determine final coverage. And these laws and regulations and rulings are those that will always prevail. CMS prohibits recording of this webinar for profit-making purposes. We ask that you do not record the presentation. We will be creating an encore presentation, and you may use that for future reference. Here then is the agenda for today's webinar. This is exactly what the advertisement stated. Today, my goal is to share with you the most common reasons for claim rejections and denials for urology claim submissions to WPS. I'm going to define rejections and denials, reveal the reasons for rejections and denials based on the data that I pulled and analyzed. I'm also going to discuss ways to fix and avoid these, and I'll be providing you with many, many resources. Now, this is a lot of information to cover in 60 minutes. I'll be moving quickly through the slide deck, and I may ask you to review some of the information following this slide presentation. That information is mostly a list of helpful sources. Now, if you have questions, I will remind you later how you can send them. But if you think of one along the way during this presentation today, just pop it into the chat, and Bailey will be monitoring the chat, and she'll post those questions if time permits. Based on the American Medical Association's copyright notice for CPT codes, descriptions, and other data, I've included this CPT copyright notice in the presentation materials. Your continued participation in this presentation infers that you agree to the terms of this copyright notice. Now, in order for me to discuss rejections and denials, I do need to provide a bit of information about the claim process. Based on the law that requires it, most providers submit claims electronically. Reports generate to confirm claim receipt and report more specific information about data requirements. Now, one of these reports is hyperlinked here on this slide in your presentation materials. It's the 276-277 report, and the companion guide is what's actually hyperlinked here to help you understand the claim requirements and know when you need to correct or submit. We refer to those edits when a claim comes into WPS as pre-pass edits. Now, claims that move past those pre-pass edits will generate a remittance advice, also known as the RA. Sometimes people call it the remit, other people call it the notice. These remittance advice or RAs are available in two formats. Most people receive the electronic remittance advice or the ERA, and there's also a standard paper remittance or SPR. Now, with few exceptions, as I mentioned, most providers are going to receive the electronic remittance notice. Now, the RA provides important information to the provider. For adjudicated claims, you can find information about adjustments and denials, even missing items, and sometimes even information about refunds and offsets. When you're reading or looking at the remittance advice, you will see various claim adjustment, reason, and remark codes. These are typically in an alphanumeric format. When claims pay differently than billed, there will be a claim adjustment reason code that appears on that remittance advice. Now, sometimes a remittance advice remark code will also appear, and these remark codes expand on details that are described by a reason code to provide more information about that adjustment. Now, another type of code that appears on the remittance advice is a group code, and group codes assign financial liability for any unpaid balance on the claim. A CO group code stands for contractual obligation, and this means that the provider is liable and you cannot bill the patient. A PR group code means that the patient is financially responsible for that unpaid claims. Now, we hear a lot of comments about those codes, those reason and remark codes. Providers often, when calling into customer services, make a statement that they believe that these codes are too cryptic, or that they even contain some outdated acronyms. Now, while we really like to help, it is another contractor, not WPS, who maintains these codes for CMS. You can find a link to the code lists on the Washington Publishing Company's website. It is on their website where you can find contact information should you wish to contact them and suggest a change to the code lists, including those code explanations that I just talked about. Now, this slide shows you a side-by-side comparison of rejections versus denials, and it's really important to understand that these are very, very different. I think many of us, myself included, often use these words interchangeably when we really should not. Let's talk about those differences. Rejections are unprocessable. We can't process a rejection. They are returned on the front end. The remittance advice does generate, but those reason and remark codes on it will tell you that we're rejecting the claim or it's unprocessable because something's illogical. It doesn't make sense. It's missing or even incorrect information. Because these claims are never processed, they have no appeal rights. What you need to do is fix it and resubmit the service. Now, I've included on the left side under the word rejection, a couple of those remark codes or group codes that will appear on a remittance notice for a rejected claim, and they are NA130 and CO16. When you see those, it should alert you to the fact that this is a rejected claim. It is not processable. It's unprocessable, and the patient isn't liable. You need to fix it, resubmit it. A denial, on the other hand, is a claim that is actually adjudicated. Services could be denied, or a claim, an entire claim could be denied for a number of reasons. They're listed here. It could be due to a law, which is a statutory requirement. Perhaps we deny a service because it doesn't meet Medicare's medical necessity guidelines. This would include any utilization guidelines or frequency parameters. Those are all medical necessity type rejections. Another reason claims are often denied is due to eligibility. It could be eligibility for the beneficiary. Maybe the beneficiary is not eligible for Medicare on the date of service. And it could also be an eligibility denial because the provider doesn't meet Medicare's criteria to bill for that particular item or service. When you receive a remittance notice for a denied claim or a denied claim line, most often, there's just a few exceptions, most often the MA01 code will appear on that remittance advice. And what that does is provide the appeal rights for that denied claim line or claim. For denied services, of course, the patient liability is determined. It's a case-by-case basis. All right, now during the next few slides, I'm going to discuss whether you need to correct or appeal the claim determination. Now, after reviewing your remittance advice, you're going to need to choose an action to take. For an unprocessable or rejected claim, you're going to need to fix that error and resubmit the claim to Medicare or resubmit the claim line that denied. If the claim or claim line denied, I said denied, I should have said rejected, I just caught myself, folks. So those rejected claims are going to need to be fixed and resubmitted now. If, on the other hand, a claim or claim line denied, very different than rejected, there could be multiple actions that you have to choose from. You may be able to simply resubmit the service. You might use the clerical error reopening. We call this the SIR process to fix a clerical error. And CMS defines clerical errors as human or mechanical errors on the part of the party or the contractor, meaning the provider or the contractor. Another action is to consider an appeal. The remittance advice will provide those appeal rights. I just talked about that on a previous slide. You'll see that MA01 code on the remittance notice to let you know that you do indeed have appeal rights. And I'll talk about appeals just a little bit later in this webinar. Now, registered users can use our Secure Net Access portal. We call it SNAP for short. That's the transactional or secure side of our website. You can use SNAP to render or even request a clerical error reopening, or you can use SNAP to request an appeal. And these are just some of the self-services tools that we offer, and they really do offer the most efficiencies for both providers and for Medicare, allowing a cost savings for both. Now, our portal user manual provides illustrations and step-by-step instructions on how to use the portal features. And I have the WPS website in here. I'm going to make it bigger so you can see it better. If you're looking at the WPS website, and I have included, of course, links to all of these resources that I'm talking about today in your presentation materials, but this is the homepage of the WPS website. Right here near the top in this big blue box is where you can choose to register for SNAP. That's the Secure Net Access portal, or find our portal user manual. That is the illustrations and step-by-step instructions on how to use the features of SNAP. This also, of course, allows you to log in when you choose to log in and use SNAP for whatever functionality it offers. Another place you can find a link to that portal user manual on any page, and I'm just going to move around within our website here, just randomly choosing things, is to scroll to the bottom of any WPS web page, and you will find right here under Educational Opportunities a link to that portal user manual. And we do have several YouTube videos about our portal. You might find them of interest if you're seeking information about using our portal. So just some good information there of that portal. Remember, it's a self-service tool. that you can use to render a clerical error in the opening or request one, and also request an appeal as well. Now, I promised you or told you that I would talk a little bit about appeals, and I do so here in the next couple of slides. For claim denials, as I mentioned, you can most often request an appeal. The purpose of the appeals process is to ensure the correct adjudication of claims. Now, physicians, suppliers, and beneficiaries all have the right to appeal claim determinations that are made by the MACs, the Medicare Administrative Contractors. The beneficiary or his or her representative may request an appeal on any service that's processed for them, and providers and suppliers may appeal services for which they accepted assignment. For unassigned claims, providers and suppliers can act as the beneficiary's representative, but the beneficiary would need to sign an authorization statement allowing them to do so. Additionally, providers and suppliers may request a redetermination on an unassigned claim if Medicare denied the service as not reasonable and necessary, or when the provider or supplier has billed in excess of the limiting charge. And in that case, the provider or supplier, of course, must refund any fees collected from the beneficiary. Now, there are 5 levels of appeal. The first level of appeal is called a redetermination, and it is the only level of appeal that is rendered at the MAC. So it is the only level of appeal that WPS renders. Timeframes apply to all 5 levels. There are timeframes for the submission of the request for the appeal. And there are also timeframes that apply to the contractors that are rendering those decisions. There is also a minimum amount in controversy, we call that an AIC, that applies to 2 of the levels of appeal, and that is level 3, level 5. You'll see them listed here on this slide. Level 3 is that administrative law judge or ALJ hearing, and level 5 is federal court review. Now, you can combine similarly denied claims in order to reach the amount in controversy for levels 3 and levels 5. Here are a couple of resources. The first one is one that you will find on WPS's website called How to Appeal a Claim Determination. Gives you instructions on how to appeal a claim determination. And the second one there, and also showing on the right-hand side of this claim, is one of my personal favorite resources that applies for appeals. So I want to share that with you. It is one that is updated annually, and I'm going to go ahead and open it. It is available on the CMS website. Of course, I've linked to it in your handout materials. And it's opening here, and I'm going to drag it over so that you can see it, make it a little bit bigger. I really like this resource on CMS's website because it shows all 5 levels of appeal. There's the first level, the second level, third level, fourth level, and fifth level. It gives you the name of those levels of appeal. Remember, I said the redetermination is the first level of appeal, and it's the only one that's done by the MAC. I told you that there are timeframes that apply to requesting an appeal and then for the contractor to make their determination. Over on the left side of this flow chart is the standard process, standard initial determination or appeals process. And then on the right side is that expedited process that applies to some Part A only. This webinar today is designed for those of you that submit claims on the 1500 claim form or the 837P professional. So the standard process applies to those of you that are talking to in this webinar today. So 120 days to file the first level of appeal, that is the redetermination. The MAC has 60 days to make their decision. Then you have 100 days from the date of the notice for the appeal to file the second level of appeal, which is rendered by the qualified independent contractor. It's called the reconsideration. They have 60 days to make their decision, and so on and so forth. I do want to point out to you that those amounts in controversy for level 3 and level 5 show here on this flow chart. That's another reason why it's one of my favorite resources. And right here says that the AIC is greater or equal to $190 for the third level of appeal. And of course, you can, combine similarly denied services in order to reach that minimum amount of controversy. And the amount of controversy is greater than or equal to $1,900 for that fifth and final level of appeal, that in federal district court. The AIC are subject to change on a yearly basis. So you do need to be aware toward the end of the year, if you're looking at this resource on CMS's website, make certain that it's up to date, because when the calendar year changes, the amounts may also change. One place to look would be right here at the bottom, since this chart reflects the amounts for calendar year 2025. So a simple way for you to notice and recognize when CMS makes that change or updates that flow chart that they've been using for a number of years. It's a great tool. All right, now at this point, I would like to start focusing on that data, which is really the focus for this webinar today, just as I advertised. Now, I used a tool called the Medicare Claims Dashboard to pull the data that I plan to reveal and share with you today. The Claims Dashboard is an interactive tool that was designed by our data analysts working in our data department. We call it here Insight. That's the name of their department or their unit. They mine the data. They, look for data trends. Sometimes medical review will ask them to take a look at some data or pull data. So they work very closely with medical review, among other tasks and responsibilities. And they created this dashboard so people like Bailey and me can go out and take a look at those most common rejections and denials. And we usually look at a 3-month time or snapshot at a time. We can compare, we can look at trending to see how things are changing. Is it improving or not? Do we need to do education on XYZ or not? So on and so forth. This is the requirement that CMS has for us. It's in their internet-only manual. It says that we will provide this type of education in order to reduce the number of rejections and denials and to avoid them altogether. So there are different ways for us to view the data that I'm talking about in that dashboard. We can, in an instant or at a push of the button, look a push of your enter key or your click of your mouse, look at and view data for rejections. We can look at denials. We can drill down. We can look at a state and even a particular county or counties. We can view this data by reasons for rejections and denials. We can also look at CPT HCPCS codes, and we can even drill down by specialty. And that's what I've done today for the data that I'll be presenting to you. Those most common rejections, most common denials for specialty, for urology specialty providers. That's specialty 34. And of course, I already mentioned the trending is something we can look at. So the data that I'm sharing today is all specialty 34 claims submitted for jurisdiction 5 and jurisdiction 8. So this means the states of Iowa, Kansas, Missouri, Nebraska, Indiana, and Michigan. I looked at Part B data only. So all of those claims, Part B. Now, while this dashboard does allow us to drill down by a specific state or states and even counties, I pulled data for the entire jurisdiction. We use what's called data slicers to filter our results. It's really a variety of drop-down menus that are used for us to choose the data that we want to view. And for those of you that are wondering what a specialty code is, I mentioned specialty 34 a couple of times. You can see it here on the slide. It is during enrollment that providers self-designate a specialty. Now, most providers can designate a secondary specialty. It is only that primary specialty, the one self-designated, mostly self-designated, some providers don't self-designate, that is used during initial claim processing. Now, there are some situations where a provider will request an appeal. They'll stipulate their secondary specialty in order for Medicare to make payments. So specialty code 34 is urology. Now, I pulled claim submission dates November 1 of 2024 through January 31 of 2025. And our data team last refreshed the data on February 10th, 2025. So I had to allow time to pull this data together, analyze it, and then, of course, get it onto these slides. And that's what I'm going to show you next. I'm going to review those most common reasons for rejections and denials, beginning with rejections. These are the most common reasons why urology claims for Part B WPS rejected for that time period I just talked about. Missing, incomplete, invalid name, strength, or dosage of drug was the #1 reason why we are rejecting Medicare claim or these urology claims at WPS. Missing, incomplete, invalid, or ordering primary identifier was the #2 reason. Number 3 reason for rejections of our claims for your specialty is that the claim must be submitted to the railroad board. Invalid or missing modifier is the next most common reason, followed by facility lab name and address or PIN missing from the claim. And to round out these on this slide, description of the service was missing, not on the claim at all. You need to fix it, resubmit it. You do need to fix it, resubmit, or fix and resubmit all of these rejected claims or claim lines. Some of those reason and remark codes do tell you specifically you need to submit a new claim, but for all rejected claims, you need to fix it and resubmit it. Those are the top reasons. Now, I want to reveal to you the most commonly rejected codes or CPT or HCPCS codes for specialty 34 claims submitted to WPS Part B only for those dates that I revealed a little bit earlier. Now, the webinar description states that we're going to review those reasons for common rejections and denials, and this slide reveals the most common reasons for urology claim rejections, and they are listed in order here for these particular CPT codes. The most commonly rejected codes, I've grouped these together because the reasons were really all the same. They might not have appeared in the same order, but these, of course, are urinalysis procedures, and it makes sense. It's urology specialty claims, but these are the most commonly rejected codes for your specialty based on the data. Why are we rejecting your claims for urinalysis? Might not be the reason you thought, but it's missing, incomplete, invalid, ordering primary identifier. It needs to be on the claim. You need to add it, fix it, resubmit it. Claim must be submitted to railroad board. That, folks, is those situations where the Medicare beneficiary is a railroad retiree and their claims are processed by the railroad contractor, which is Palmetto GDA. So those claims should not come to WPS. Look at that. #2 reason we are rejecting urinalysis codes for your specialty. Next is that the lab was not approved to perform services under CLIA. This is the Clinical Laboratory Improvements Act. It requires that laboratories be certified to perform certain lab procedures. It's a process they have to undergo. When they are approved to render those lab services, there is a certification number that is provided to the lab, and that number needs to be placed on the claim when you're billing for a CLIA lab service. So if it's missing or the lab isn't approved to perform that service, the claim is going to reject. Next, patient insured, HIC age and name do not match. Now, this is one of those situations that is a little bit cryptic. What this is really meaning is the HIC N, not the HIC age, health insurance claim number, but I put H here on this slide because that's how it printed out in the data that I looked at. So that is what I'm revealing to you. The patient name and their health insurance claim number or the Medicare beneficiary identifier have to match exactly. This means if there is a middle initial on the patient's Medicare card, that middle initial needs to be on the claim that you submit. It needs to match. If they don't, the claim could reject. Invalid or missing modifier is another reason why these codes are rejecting. And the other one is the last one here, the last most common reason these codes are rejected is that the claim should have been sent to United Mine Workers of America for processing. So that's really similar to that second bullet where the claim must be submitted to the railroad board contractor. In this case, the claim should be sent to the United Mine Workers of America. Those co-workers that are Medicare beneficiaries, former co-workers, their claims are processed by United Mine Workers of America. And those, of course, would be something that you could check in on Medicare's eligibility files. So here then on slide 23 is the next most commonly rejected code for your specialty. It's the J9030, which describes that live intravesical installation. We are rejecting this code most commonly because the claim is missing or has incomplete, invalid name, strength, or dosage of that drug that's being used. Missing, incomplete, invalid ordering primary identifier is the second most common reason for rejection. Claim must be submitted to RRB, invalid or missing modifier. You can see by looking here, I'm not going to read through all of these, that they're very, very similar to the same reasons why claims, urology claims, are being rejected by WPS or those urinalysis procedures. Here then is the next most commonly rejected code, 99213, and it's really never any surprise when an evaluation and management shows up on these most commonly rejected claim in the data. And the reason for that is that approximately 40% of all the claims that we process include an E&M code. You can see here reasons why this code is rejecting. The facility name and address or PIN is missing. Claim must be submitted to Railroad Board, United Mine Workers. Here's a new one. Place of service conflicts with procedure code. So in this case, what that means, what you need to fix and resubmit is the fact that this 99213 is an office service, outpatient service. You need to make certain that the place of service that you're reporting does not conflict with the CPT description for 99213. And finally, name and number do not match again. Very, very similar, all of these. Here's one, G2211 that popped up in the data that I looked at. This is an add-on code that can be billed in conjunction with office or outpatient evaluation and management or E&M services. Now, those are codes 99202 through 99215. This code is used to recognize the complexity of that patient relationship over time. And it really is designed to capture additional work in managing patients with ongoing or complex conditions, or those who are the primary care provider's ongoing focal point. So here are the reasons this is being rejected. Fix it, resubmit it, folks. Claim must be submitted to Railroad Board, invalid, missing modifier. Here's a new one, unable to obtain primary insurer information. This occurs when you on a claim tell us, yes, there is another insurance that is primary to Medicare. However, you don't fill in, or the provider doesn't fill in, the additional items on the claim that need to be reported when you say yes in item number 11. I'm going to show you a crosswalk in a little bit that tells you whether the item on a claim is required or situational. And in this case, it would be situational. If you told us that there's primary insurance, you need also to give us information about that primary insurance. Name and number doesn't match. We got more Railroad Board rejections. Primary payment information was not reported. This is one of those situations where Medicare is the secondary payer. So primary payment made by that other payer was not reported. Facility, lab name, and address are PIN missing is the next. And here is J9217. This describes, and I'm not certain I'm pronouncing it correctly, leuprolide acetate, this drug rejected most commonly for those reasons here on this slide. Missing, incomplete, invalid name, strength, or dosage. United Mine Workers should get the claim PIC number, or the Medicare beneficiary identifier rather, and the name on the claim don't match. Field 11 of the 1500 claim form must be completed. You can see it says HCFA. I wrote that because that is exactly how the data prints out. Of course, it's no longer the HCFA 1500, it's the CMS 1500, but this is how the data pulls. And then, of course, the claim must be submitted to Railroad Board. Back to that field 11. This is the field on the claim, on the paper claim that asks you, or the electronic equivalent, that asks you, is there other insurance that's primary to Medicare? You can't leave that blank. It is an item on the claim that is required. So if the answer is no or none, you need to put none in that field, or the electronic. You can't just leave it blank, or your claim will reject. Now, I mentioned to you a little bit earlier that we can look at trending. So I wanted to show you an example of that here on slide 27. I chose, when I looked at the trending report for data for those 3 months, I chose this rejection. Place of service conflicts with procedure code. We have one of those in the actual data that I revealed to you. So submit new claim. So like at the touch of a button or a click of the mouse, I could see there was 29 rejections the current 3 months, but only 5 the prior 3 months. This is a 24 claim increase and a 480% change in the number of rejections. So this, folks, is what we use to monitor those spikes or trends in claim rejections and denials, so we know where we need to focus our education. And that's exactly part of the reason why I'm presenting this to you today. I'm telling you the most common rejections, the most common denials, and how to fix them alone. All right, now we talked about rejections, which are very different from denials. Now I'm going to present the denials. Duplicate charge paid. It will fill in a date on claim and then provide the ICN for you. 6,899 denials. Think about that in terms of a dollar associated with every one of those denials. That costs the provider money, and it costs the Medicare Trust Fund money. We are denying thousands of claims every single day that do not need to be submitted to Medicare and should not be submitted to Medicare, right? Collection of fee-for-service during periods of managed care. This is one of those kind of cryptic reasons, over 2,000 denials for your specialty. What this means is that the beneficiary elected a Medicare Advantage plan. So Medicare Part C should process the claim. In this case, this is fee-for-service during periods of managed care. So that claim should really have been processed by the Medicare Part C plan, which is Medicare Advantage, or MA as some people call it. The next most common reason for denials is that the referring provider on the claim is not eligible to refer the service. Almost 1,800 denials. The next is pre and post-op care included in surgery. You may not bill the patient. Medicare reimburses for surgical procedures kind of in a global surgery package, if you will. It includes the pre and post-op care related to that particular surgery. So if billed separately, it's going to deny, and you can't bill the patient. It's part of that global surgery package. We have multiple videos available on our YouTube channel that explain global surgery and how to bill, how to use modifiers appropriately to show when those services are or are not part of that pre or post-op care or intraoperative care. So I'll be providing those for you in a bit. Last is claim must be sent to the EGHP first. And what this means is employer group health plan. So in this case, the claim was submitted to Medicare, but it should have been submitted instead to the employer group health plan or the primary insurer. So let's look at the denials by codes for urology claims. Dupes, pre and post-op care included in surgery, fee for service during periods of managed care, and Medicare secondary payer. All of those which we're hitting for the most common reasons. Not surprising, 99213, 99214 are both evaluation and management services. These are the most commonly denied codes for your specialty. And again, no big surprise because we get a lot of claims with EMN codes on it. But we do want to reduce the number of denials and make sure that you're able to receive payment when you are eligible to do that. All right. 99214, 3 and 14, more reasons for denial: not covered when performed, referred, or ordered by this provider. 1 visit or consult per doctor per day. Do not bill the patient. In other words, don't bill more than 1 E&M service on the same day by the same doctor for the same patient. This one, the time limit for filing your claim is expired. No appeal rights. And a little bit earlier on, I talked about a reason or remark code, the MA01, on a claim that provides appeal rights. This is one of those exceptions where that's not going to show up on the remittance advice because this has no appeal right. We do have on our website, pull it back over here real quick. And this is just an example of the many, many resources that I've given you at the end of your presentation materials. Timely filing. I'm a searcher, not a navigator, so you'll often see me when I'm presenting or showing the website, just simply searching. I typed the word timely into our search, and then here are potential matches, and right at the top is timely filing of claims. This is a great resource that talks about timely filing. You have 1 year from the date of service to submit the claim to Medicare. If you have a reason why we might extend that late filing limit, you can file for a waiver to extend the timely filing limit. This resource tells you, right now I'm showing jurisdiction 8 Part B, so that's why you see Indiana and Michigan. If you want to switch from J8 MAC Part B to J5 MAC Part B, you can do it here on this ribbon at the top of the web page. So then you have the J5 state mailing information here. But what's happening a lot, and we're trying to avoid this, so we've been hosting webinars to discuss it, is this situation right here. When the denied claim is not filed within the time limits due to a third-party error. Providers often ask us to reopen claims when another insurer comes back, even as many as 7, 8 years later, and recoups their payment, saying Medicare should have paid this as primary. So the provider comes to you and says, we want our money back, submit to Medicare. This particular resource on our website has a link to the CMS Internet-only manual publication that addresses this third-party error. And it says right here in this italicized language that third-party errors in making primary payment determination does not constitute good cause for the purposes of reopening an initial determination or redetermination when Medicare processes a claim in accordance with the information in the system. So this is what says when that happens, we are not going to approve a waiver for that timely filing. So I wanted to point that out because it is an issue that we've been seeing a lot of lately, not just for urology claims, but for others as well. Now out of the way and moving on. Physician or supplier not eligible to receive payment. That would be an indication for you to contact, or first of all, use self-service, check PayPost, the provider enrollment chain and ownership system. It's the online enrollment system. Check your records to make certain that everything is correct, eligibility dates correct, and so on and so forth. Or you can work with our provider enrollment staff in order to do that. 51798 is another most commonly denied code. I did receive a pre-submitted question on this. Actually, it wasn't a question per se, but someone was asking about documentation requirements for this code. if the amount only is appropriate or if use of the ultrasound needs to be specified. And to answer that question, the code description is measurement of post-voiding residual urine and or bladder capacity by ultrasound non-imaging. So that means that your documentation should include the reason the post-void residual was obtained, the post-void amount, and it should indicate that ultrasound was used and how it was used in that medical decision-making, because ultrasound is part of that CPT code definition, so it should be documented appropriately in your record. So here then are the reasons we're denying this particular CPT code. Excuse me just a moment. For this one, service and units of service are exceeded. What this pertains to are those medically unlikely edits that CMS has published on their website. This means that the units reported on the claim were that exceeded that MUE that's published on CMS's website. There's a chance it could not be published because some of them are actually confidential, but at any rate, the units of service exceeded the amount allowed by Medicare, and that's why we're denying this service. The number one reason we're denying that code. The number two reason, it's a duplicate charge. Again, I've been in Medicare many years. We have been talking about duplicate claims, duplicate charges, duplicate denials for all of those years I've been here, and it's over 40 now. It just continues to kick us in the pants. You know, if you use a billing service or you bill on a cycle every 30 days, you know, make sure you're doing your due diligence, checking to see what happened with that claim you've already submitted. You know, look for the remittance advice that tells you why we may have denied it. Don't just resubmit or submit a new claim. It's going to deny as a duplicate. If you do it again in 30 days, it's going to deny as a duplicate, and so on and so forth. The next one is the code modifier and facility disagree, then a new claim. So this would be one of those situations where you can simply submit a new claim if something's denied. Collection of fee for service during periods of care again. Here's a new one. Medicare does not pay for 2 surgeons for this procedure. You can look at the CMS relative value file to see if more than 1 surgeon is allowed for this procedure. It's not. I don't know what happened here in this case. You know, sometimes we have to, when data spins out one of these reasons like this, we have to do our due diligence and go looking for the reason why that happened. You know, maybe 2 different files were submitted to us with 2 different provider names on them, and that's why there's 2 surgeons billing for this procedure. I can't tell you that without looking and digging, but that's part of our responsibility. When we analyze this data, we need to look to make certain there's a reason behind that, that it may not have been a billing, well, it's a billing error, but it's one that we can easily identify and have fixed. And the next is SNF, skilled nursing facility, episode of care notice has been filed for this. That means that this service was denied because the patient is in a covered Part A stay in the SNF, and it's not separately billable as such. SNF consolidated billing is what you're going to look for. Here is a CPT code 84153. This is the prostate specific antigen. Denials such as Medicare will not pay for this service for this condition. The number one reason here means that it didn't meet Medicare's medical necessity requirements. So this should be an indicator to you that the denial is policy related. It could be a local policy, or such as this case, it's a national policy. And the NCD number for this CPT code is 190.3, and that includes the indications and limitations of coverage, what conditions we would or would not pay for this service. Duplicate is here, referring provider not eligible. There's Medicare secondary payer issues, not covered when performed referred by this provider, more secondary payer, and then of course another one of those denials that's related to that scope of the CLIA certificate. One last code that I want to go over here is a top denied code is the G2211. This one also showed up on rejections. It was a commonly rejected code, but based on the data analyzed, it's also a commonly denied code. So the services are not payable with other services rendered on the same data service. This code is only payable with certain items or services. So you would need to check that. Duplicate, collection of fee for service during managed care. So that's Part C beneficiary. The procedure must be billed with a primary service. G2211 is an add-on code. So if the primary service is not billed, the G2211 is going to deny. We have Medicare secondary payer here, and then procedure not covered when performed, referred, or ordered by this provider. More denials. These are your analysis. Look at that. Duplicate, 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 duplicate. They continue to deny claims that are duplicate. They don't need to be submitted. They should not be submitted. They cost everyone time and money. We can only pay one initial visit per specialty. This one popped out, and this would be one that we would need to take a look at because these are laboratory services. Why is a new patient visit code reason for denial printing out here? So I wanted to include that to show you that sometimes for whatever reason, there could be a skewing in the data, and we would need to verify the data, of course, to determine any need for education or correction to claims. One visit consult per doctor per day. Similarly, we would have to look into that. I suspect maybe a large provider, since those two denials are similar, maybe a large provider submitted a batch of claims that had some incorrect information on. And again, provider not eligible or certified on this date, and time limit for filing has expired. Here's a training example. The procedure must be billed with the primary service, 172 claims the current 3 months, only 15 the prior. That was a 157 claim increase, 1,047% change. So that looks like we might want to take a look at this reason, do a little more digging to determine the need for education. So these next few slides, I'm not going to go through every single one of them. Just tell you that, as promised, we would provide you with ways to fix or correct these rejections and denials. And the fixes, of course, would be related to rejections because you need to fix it, resubmit it. You know, what do you need to verify? What do you need to do? So for those rejected claims, because they were railroad, they were United Mine Workers of America, you know, railroad retiree or coal miner or miner, or a Medicare Advantage plan eligible beneficiary, you would need to make sure you're submitting the claim to the correct provider. Provider number fixes, you know, make sure you're keying everything correct, your enrollment records are up to date, the ordering provider information was rendered. And if you are billing for a provider that's associated in a group, you need to make sure that that rendering provider is associated with the billing provider in your enrollment files. Modifier issues, you know, make sure your required modifiers are present, that you haven't typed them wrong. Make certain that modifier was valid the date of service and that it matches the procedure code. We have on our website, if you look for modifiers, there's more than one way. You can look under the claims topic center. We have a modifier web page. This is just when you do a quick search. But if you go to the modifiers webpage and scroll down, you will see for many modifiers, we have fact sheets that we have written and published. The nice thing about the fact sheets is that it provides you with the definition, gives you appropriate use and inappropriate use, and sometimes we give you the actual procedure code or a little bit more information so you can determine how to correctly use a particular modifier or not report it. We have duplicate denials. I talked about those already. Don't just auto resubmit before you've established the status. Make sure you're billing appropriately, you're reporting the appropriate modifiers. I mentioned to you that we have global surgery education available. Here's the link to those relative value files that you can use to find the global periods for particular CPT codes. More information for avoiding global surgery denials. Timely filing. I already showed you this resource on our website, which provides you information about potential liability, reasons why we could extend that filing limit or allow the waiver or not. CLIA denials, that Clinical Lab Improvements Act I told you about. Providers have to get certified when they're rendering certain lab services. When you're certified, you need to report that CLIA certification number on the claim when billing the lab. Here's some information that's included so you can avoid E&M denials. It is in the internet-only manual that CMS provides instructions for E&M services. We had some MSP denials, Medicare secondary payer denials, HIT as those most commonly, the reasons for common denials for your specialties. So I've included MSP information and resources here. I do have to tell you that I discovered yesterday that this, the MSP questions and answers is no longer available. So if you click on that, you will not get to that information. I apologize for that. It was too late to get the information out of your handout. And another good reason to remind you of that disclaimer we use at the beginning of our education. We talked about MUEs today, those medically unlikely edits, those situations when services are being denied. It was the, I believe, 51798 CPT code being denied because, sure, that was the full, I think back here, 51798, yeah, it was. Because the units of service were exceeded. That would be these medically unlikely edits. More resources and tools. We have claim form instructions. I want to show you this real quick. I know we're getting close on time, but this crosswalk crosswalks you from a paper claim form to an electronic claim form. These chapters here on this slide are instructions for paper claim forms, electronic claim forms, and Part A claim forms. I put in there just for good measure. That crosswalk, you can just link to it, or you can find it this way. I'll show you real quick. Go to our homepage under quick links. You'll find EDI, that's Electronic Data Interchange. They have their own website. You see it right now if you scroll down. Choose Medicare. You can find links to helpful companion guides, those that I talked about earlier when I talked about pre-pass edits, the 276, 277 report. Here is that Medicare resource, which is a crosswalk, and I'll show it to you real quick. But this is another one of those things I like to show people when I'm providing education that they say, wow, I never knew about that. So this is the crosswalk, and it shows you in column 1, the item of the claim form. So if it were a paper claim form, this would be item 13. This would be item 5 here. Item 1 tells you the narrative. What is it on the claim form? The requirements for the version 5010, which is the electronic claim form. And then where does it go on the electronic claim? If it goes in item 2 on the paper claim, where does it go on the electronic claim? Well, it's right here and here. Okay, so I mentioned to you earlier about those situations that are required or situational. When do you have to put it on the claim? One of the examples I gave you was that missing information about the other insurance. Okay, so if you enter in item number 11 that there's another insurance, then some of these plans that are these items that follow are situational, because this is a data element, as it says right here, that must be completed if other conditions exist. Now, if you see an R, that means the data element is needed in order to process a claim. What does that mean? It means if it's missing, it's unprocessable. It's going to be rejected. So that is the crosswalk. I'm really short on time here. I apologize. IVR, this is where you can find claim status and details. It's self-explanatory here, but you can go back to and find. Similarly, you can use our Secure Net Access portal. I talked about it already. You can check eligibility, check claim status. You can look at claim details. Often, if you're looking at a claim line detail, you're seeing this claim line denied because of ABC. There will be a button that appears in SNAP. It says more info. So, for example, if a claim line denied due to policy, that more info button will likely take you to that policy. All right, we're just wrapping up here, folks. I see some of you have to leave. running a little long today. We had a lot of rejections and denials for your specialty that I needed to explain a little bit better. Here is our resource for claim denials. This is our resource on our website on how to correct a corrected claim. Then comes the denials one. And the nice thing about both of these is that it gives you those reason remark codes that print out on the remit. So if you see a reason or remark code on the remit, come out to these resources and find it. It tells you exactly what you need to do to fix it or resubmit it. Here are WPS resources. I talked about the crosswalk already. Here's where you find our website. Here are more resources for education. Our YouTube channel, I talked about it. It includes those videos about Medicare Advantage and global surgery. Here are CMS resources for checking eligibility so you can avoid those denials. This review contractor is an interactive map that helps you understand where to submit the claim. I did it in there. You can just simply click on date and find all the different contractors for that state. So you know, where do I send the information or where can I find information on Railroad Retirement Board? What if your beneficiary has home health and hospice? This provides you that contractor directory. Ordering and referring website is one. And if you go to this page, you can do a search for any provider by name, and it will give you their NPI and tell you whether they are approved by CMS or eligible to order and refer services. It's a great, great resource. A lot of people don't know about that. E&M. Here are all of the resources, the guides CMS published, their webpage, the playlist. This is just simply a checklist to say, did I do what I told you what I was going to do today? Did I define rejections and denials? Yes. I revealed the reasons for common rejections and denials. I discussed how to fix and avoid them, and I provided you with resources. So I did do everything I set out to do. This is where I normally would take questions and answers. We're short on time, but I promised you and mentioned to you earlier, if you placed a question in the chat that I have not got to, one that is not claim specific, or if you send me a question within the next 7 days, I will get a response either directly to you, or I will make a list of questions and answers and send it to everyone participating today. Some of you might be seeking CEUs for education. In a few minutes, you will receive an automated email. It's coming from WebEx, not WPS. It's going to thank you for attending. If you are seeking CEUs, do not delete it without reading it. It is this automated email, this thank you email that includes your certificate of achievement. It's going to look like what you see in the lower red box. It's going to have your name, your contact hours, the name of this program today, and the date. If you don't see that email, check your spam or your junk folder. If it's there, make sure that you add that WebEx email to your safe sender list. So if you come to another webinar by WPS, this won't happen in the future. Now listen closely, please. If any of you join by phone only, in other words, you listen, but you aren't seeing my slides, you might have a handout, but you haven't viewed the slide presentation, WebEx will not send you an automated email because they don't have your phone number. If you need a certificate of achievement, we will get one to you. What you need to do, send an email to the WPS mailbox. It's shown at the very bottom of this slide, and Bailey's going to put it in the chat. Put today's date, the name of the webinar, the telephone number you called in from, and we'll send you that certificate of achievement. We don't give you CEUs, we give you a certificate that you need to present to an accrediting body or organization so they can consider awarding you CEUs. Here is exactly how you can send those questions that you haven't placed already in the chat to me for a period of 7 days. Send the email to our education mailbox. In the subject line, put today's topic, which is urology, rejections, and denials. Remember that Bailey and I can't help with claim-specific questions. We don't have access to claim information. It is customer service that does. If you have claim-specific questions, you do need to send them to customer service. I apologize for running over, folks. The last thing I want to talk to you is this survey that is so very important. In a few minutes, or please take a few minutes to complete a survey. Tell us what you like, what we could do better. Tell us about topics you want to hear about in the future. Your feedback is really important. We have taken so many actions based on your requests or your notifications in this survey, your feedback, and made them happen. This is a wish list of sorts. It's so important that we're going to give you another chance to complete it. When you exit the webinar today, you're going to be redirected to the CMS Qualtrics page for the survey. You're going to get a message that looks like this box on the bottom with the yellow triangle at the top. If you've not already completed the survey, that gives you another opportunity to do so. On behalf of myself and Bailey and the entire provider outreach and education team, we do want to thank you for your participation. We know you're busy. We look forward to your survey comments and hope to have you join us for future events. You may now disconnect from today's webinar. Thanks, everyone. I appreciate you so much.